Lastly, we're going to have Stacey Collins come up, one of our expert dietitians that works with us, and give us a rundown on another very critical aspect of managing these patients, which is nutrition during pregnancy with IBD.
Thank you, Dr. Steiner. Excited to be here with you all. Okay, today we're going to talk about the pregnancy perspective or the nutrition perspective in pregnancy. I have no money. So these are the abbreviations. I welcome you to go back and explore them at a later date. This is an important topic, and I think that this clearly demonstrates from the Great American Classic Mean Girls what a lot of our patients with IBD are kind of enduring. They're handcuffed to the bathroom, literally by their symptoms. And so as a result of present-day technology, they are at risk for being misinformed. I'm sure any colorectal surgeon in the audience will attest that we might have a lot more hemorrhoids from people sitting on the toilet. But basically, we know that, as Dr. Proxell alluded to, we are at an increased risk for misinformation in this patient population. They're highly motivated, so they really want to talk to people about their nutrition. But in a 2025 narrative review, patients were unable to explore their nutrition-related concerns with their physicians. Thank you, Great American Healthcare System, because of lack of time with their physicians. But dietitians can help. And so if you are interested in employing a dietitian, we actually have a new GI credential that kind of separates and delineates GI dietitians from vanilla dietitians, and you can take any of these guidelines to your PERS at your institution and request that you have a dietitian in clinic to kind of help you address that barrier. So as far as objectives go today, we're going to talk about optimizing nutrition before conception and remissive supportive strategies for preconception. We're also going to talk about how to eat to support fetal growth and maintain maternal health along the way, all the while keeping IBD in remission with nutrition. Lastly, we're going to talk about postpartum because I feel like mothers don't get any love in the postpartum era. So the way that I frame nutrition when I talk to patients is, can we stack all the cards in your favor to control remission? And all we can control is risk when it comes to nutrition and IBD. So as a reminder for people who may not see your IBD patients every single day, iron deficiency anemia is the most common IBD-related complication, even in disease remission. I highlight this because adequate iron is associated with response to medications. And so if we're thinking of 3 to 6 months before a patient wants to conceive, we want to also be monitoring their total iron binding capacity with ferritin. This is a handout that I made for the AGA if you want to give it to patients, all about how to maximize iron absorption with food. As far as pregnancy is concerned, we want to make sure that people have sufficient iron before pregnancy. This is something that will cross the placental barrier, and we are at an increased risk for poor perfusion of blood flow to the fetus if we are unable to secure those iron stores before pregnancy. 60% of the energy from iron is going to be used for fetal brain development. So we want to make sure that this is something that's being monitored. As a reminder, hepcidin is upregulated in active inflammation. This further highlights the need to make sure that a mom is in pregnancy or in remission before pregnancy, because if that hepcidin is upregulated because of active inflammation, they're not going to be absorbing oral iron. We also have to think of the whole patient picture. Like, are they really going to want to be put on oral iron if they're not feeling super well? And then you add on pregnancy on top of that. Vitamin D is important. In pregnancy, we're looking for hypersufficiency. So well above 30, our goal in our clinic is around 50, but as close to 75 in research is inversely associated with fecal calprotectin, although this hasn't been evaluated endoscopically. Deficiency in vitamin D is associated with preeclampsia, gestational diabetes, low birth weight, and interestingly, after vitamin D was supplemented, it didn't necessarily reverse the consequences of these. So it's important to preload with vitamin D. Every clinic assessment that I have with a patient, I ask them 3 different times in every encounter which vitamins and which minerals they're taking, because this is a patient population that's such high risk for misinformation. And I guarantee you 9 times out of 10, I'll get 3 different answers from asking that question 3 different ways. So it's important to kind of consider correcting deficiencies before we're chasing them, while we're trying to ensure that a mom feels safe pursuing a pregnancy with IBD. This is a wonderful micronutrient deficiency fact sheet by the Crohn's and Colitis Foundation. I highly recommend that you just print it out and decorate your office with it. That way you don't have to remember anything. It's all there for you, and it's very simple to reference. As far as vitamin B9 or folic acid supplementation is concerned, I think everyone agrees today that this is a very important addition. Something I will highlight is that some of the most efficacious prenatal vitamins in research haven't actually been shown to have quite enough folic acid for our IBD patients. So we may need to supplement with an additional folic acid once we discover that they are pregnant. And I'll just give a quick shout out to vitamin B12 just because she didn't get any love in this. But I'm going to scoot back for just a second. Make sure that your patients are on third-party tested supplements. A lot of times my patients are coming in with MTHFR concerns. They're coming in with methylated B vitamins that are so expensive but haven't actually been shown to reduce the risk of neural tube defects in pregnancy. So we want to make sure that they are on a third-party tested supplement, and I go over USP and NSF with all of my patients. As far as nutrition before conception, there is an eating pattern that's supportive of maintenance of remission. This is not an induction therapy, and I make sure that's clear to patients. This is not a diet therapy that will ever replace your medicine. Your medicine is needed to keep you healthy. This comes alongside your medication management and supports its efficacy. Again, all we can really control with this illness is risk. So if we're thinking of reducing the risk of a disease flare in pregnancy, this is absolutely what we want to do. But when I talk about the Mediterranean diet with patients, I don't usually call it the Mediterranean diet. Has anyone ever traveled to the Mediterranean? It's a lot of cigarettes and it's a lot of espresso. And then here in Colorado, I'm like, what are they going to do if we just tell them the Mediterranean diet? They're not going to know what to do with that information. So I really try to quantify it in research. When we see that people's response to this diet is actually helping their metabolites, it's actually helping a healthy microbiome, it's actually helping their disease become more efficacious. This is the eating pattern that we know is quantifiable. And so I'll kind of sit down and go over this in detail with patients so that they understand that, yes, you can have a very small serving of red meat. No, we don't need to have a brat for breakfast, lunch, and dinner, even if that's all you feel like you can tolerate in America. Also, this QR code is fantastic. It goes to a study that Dr. Natasha Haskey, she is a microbiome researcher from Canada. It goes to a study that she co-authored with Mount Sinai, and I just recommend taking a read through it. It really helps you kind of understand how to market the Mediterranean diet to American patients whenever you don't want to say the word Mediterranean diet and then watch their eyes glaze over and roll into the back of their head. This is a way to kind of translate the Mediterranean diet to other cultures, because usually whenever patients come into my practice, they're meeting with, well, always actually, they're meeting with a Caucasian, and I love food, but it doesn't mean that I'm the expert on every single patient's culture. And if I can get them to adhere to this eating pattern, it's going to need to be culturally inclusive, and it's going to need to be individualized to the patient. I'm not going to whitewash a patient's diet. That is not my job. So this is a fantastic resource that we use in our clinic with our Latinx patients that was developed by one of our fantastic dietetic interns here at the University of Colorado, Vinca Martinez, who's now a dietitian. Okay, as far as, oh no, I misspelled pregnancy. As far as nutrition before conception, well, that is devastating. We just want to make sure that a patient is kind of at a healthy weight range, which has been sort of talked about. I'll be honest, I don't bring this up too terribly often in clinic visits with my IBD patients because usually we have bigger fish to fry. But once I have rapport developed, if it comes up, it's certainly something that I will talk about because we want to make sure that patients understand sort of what their recommended weight gain amounts should look like. Sometimes I'll have patients come in and they're like, my sister gained, 85 pounds in her pregnancy. How much should I gain? And so sometimes we talk about like loose targets with these patients just to kind of minimize risk of fetal abnormalities. This is the recommendations for multiples, but we don't have anything above multiples. So we'll just have to ballpark if we have triplets, et cetera, come into the clinic. During pregnancy, can we help patients actually anticipate and maintain adequate nutrition in the setting of symptoms that are going to pop up that are inevitably not fun? So the thing to kind of keep in mind with IBD is your patients are going to need more in the second and third trimester, although this has not been studied in IBD. Interestingly, the protein recommendations for pregnancies are lower than what I would calculate any person with any stage of IBD to have. And that's based on our AGA guidelines for nutrition. So I just highlight this because even though there's protein recommendations in pregnancy, this is actually far too low for IBD patients. But if you blast your patients with protein during pregnancy, they're going to get constipated, and then you're going to be seeing them for heartburn and for constipation. So just some things we're going to sort of talk through today. As far as which micronutrients matter the most, I already highlighted the pre-pregnancy ones. We also need to think about things like vitamin A. Vitamin A topicals ideally would be stopped well before pregnancy, 3 to 6 months prior. Something that I've run into in my practice, though, sometimes patients are actually eating too much vitamin A because they're starting to prioritize organ meats because they're concerned about the possibility of iron deficiency anemia. Really, one serving of organ meat puts you very close to a toxicity load in pregnancy of vitamin A. So something to just kind of keep on your radar. And again, if you're kind of reassuring patients at every step of the way, like we're monitoring you, you're safe, that in itself really goes a long way. Also, marine fish, really good for UC, more so than the actual supplements in a head-to-head study from about 2019. As far as anticipating barriers during pregnancy, I love working with pregnant patients with IBD because it's kind of like an ever-moving target. Sometimes they come in and I'm like, wow, you are not even the same person I saw last time. This is amazing. Now we're going to have to talk about food aversions to foods that you were craving prior. So something to kind of keep in the back of your mind, we don't recommend low fiber, low residue anymore. We don't do that for IBD. This is an inflammatory condition. And if patients are going to do low fiber, low residue, they're not getting exposure to any anti-inflammatory foods that are going to help their medicine be more efficacious, that are going to help decrease the risk of disease activity. But what we can do if a patient is uncomfortable with the experience of digesting low fiber or high fiber rather, we want to transition the texture to be small particle size. So very simple. You could just say instead of hummus or instead of chickpeas, do hummus. Instead of cashews, do cashew butter, etc. It's not rocket science, but it is kind of a refreshing way to kind of reframe how patients will be thinking about nutrition whenever they've been told low fiber, no fiber, low fiber, no fiber. In addition, this is something that will work both for IBD flares and for like kind of some nauseous vomiting type symptoms as well. So this is called the small particle size diet. Anticipating nausea and vomiting is super fun whenever we know that they need more calories and more protein to help grow a healthy baby. A lot of times this requires a lot of patience, a lot of tears, and a lot of, considerations of what sounds good. Because in reality, we're not going to be able to help a patient achieve like a beautiful Mediterranean diet while they're in pregnancy. We just want to get them as close to having a diverse diet as possible. So maybe we can consider protein at each crossroad when it comes to nutrition, as their nausea and vomiting will allow. But we want to make sure that that's always paired with some type of fiber so that we're preventing constipation. I highlight this just because there is in the New Zealand and Australian guidelines that they kind of go through the potential benefit of vitamin B6 and ginger. I like to recommend Preggy Pops with my patients, although the ingredients are not always ideal for people who have IBD, but you know what? Neither is nausea. So I just think this is interesting. Our American guidelines don't have this, but it's something worth considering. Ginger chews from a brand called Chimes is something I've seen some success with as well. As far as anticipating fatigue, this is where I really like to acknowledge the privilege of a support system. If your spouse or your significant other, or if your brother or if your neighbor can pre-make you some meals to sort of keep in the freezer, this works both for, those days when you're just too tired to even think about food and you find yourself in analysis paralysis. And it works great for after pregnancy as well, when you can just pop something in the oven. Heartburn and constipation go hand in hand, because with constipation, we're kind of having a negative pressure buildup. So a lot of times with IBD, patients are like, no, I'm running to the bathroom 7 to 35 times a day. And if they're not having a sensation of a full, complete evacuation, I call them morally superior bowel movements, where you're driving and you just feel like you can think clearer. And you're like, wow, that's actually how I describe this to patients. If they're not experiencing that, then they are constipated and they're experiencing overflow diarrhea. So we want to try to make sure that we're preventing that to keep them as comfortable as possible. I realized after I made this whole presentation that I did not even hit on food safety. It's like putting your name at the top of a paper. I just completely forgot. So obviously this is going to be an area of importance that you want to talk through with your patients. Unfortunately, tiramisu does count as an exposure to raw egg, and I'm devastated to have to break that news to patients. But if you need a good handout, this is a good one, and this links to it. So I recommend that you give this to all of your patients who are considering pregnancy. As far as postpartum nutrition goes, I really can't believe the level of care that new moms don't receive in healthcare. And our patients never graduate from our practice with IBD. They are for life. So if we can reestablish rapport at every crossroad, that's an important thing to consider, because we are their providers for the long haul. We've seen in ample research that there's this baby first shift where medical checkups then start to focus on the baby, and that's important. But also, what about mom? I can't believe that there are moms giving birth, getting full blood transfusions, and no one's ever checked under the hood to see if their iron came back, all while they're trying to keep a new infant alive. This is important. I also think we have kind of a interesting opportunity to really reframe C-section, especially in our patients who have a strong traumatic surgical history with IBD. We can actually reframe this as something we can get ready for, as if you were to prepare for an athletic event. So you are going to have a wound. Maybe we need to think about vitamin C and zinc supplementation until that wound closes. We want to think about hydration. High risk for kidney stones in your patients with IBD who are going to be breastfeeding, super high risk. So we want to make sure that patients understand that they need to have, a gigantic Stanley Cup on every floor of their house that's always full of water. And that's something a partner can certainly help them make sure they're accomplishing. No matter what, we want to continue the prenatal, and we want to continue to individualize both the monitoring of the disease and the micronutrients with these patients. these are the key takeaways from today. And I know this is a busy slide, but I was basically just dreaming, if we had a patient make it to every single appointment, what would a monitoring strategy actually look like? And I just kind of threw those into a timeline so that you can perhaps take this back to your clinic and consider employing some type of multidisciplinary pregnancy approach for your patients with IBD. So very lastly, dietitians can be really helpful additions to your team. A lot of what we do is consistent support. It's not necessarily rocket science, but that can save you, a few messages in your Epic chat. And that's important in itself. We can also provide personalized evidence-based nutrition counseling, empowering motivated patients to make informed decisions that support their maternal and their fetal health. And with that, thank you so much for your time and attention today.
All right. Thank you so much.